committee for the invitation and giving me the chance to present this talk. So we know the high-grade spondylolisthesis could have balanced or unbalanced spine. Balanced pelvis has different global sagittal alignment from unbalanced spine. Should not be considered as focal pathology or deformity. It's global. We should think globally. And focal pelvic parameters and global spine alignment must be respected and corrected. One important fact that almost 2/3 of the lumbar lordosis from L4 to S1, and half of that at L5, S1. So whenever you are aiming to correct the lumbar lordosis, you should keep in mind this fact. If we are talking about the alignments, as we know that pelvic incidence is fixed per patient, and it's about 57 degrees on the adult male patient, and it's the summation between pelvic tilt and the sacral slope. And it has the relation with the lumbar lordosis. So if you can see, this is just to show you the pelvic incidence, pelvic tilt and sacral slope. Both of those will give you the pelvic incidence. If the image is oblique, you can take the center of both hips, then measure the pelvic incidence. Now, if we are talking about spondylolisthesis high grade, as we said, it could be the patient could have balanced pelvis or unbalanced pelvis. Hence, the unbalanced pelvis is a vertical sacrum. The sacrum is vertical. The unbalanced pelvis group would have either balanced spine or unbalanced spine. Here, with the example of unbalanced spine. The unbalanced spine will have high pelvic tilt and low sacral slope. Now, this is an example of those patients. This is the two high-grade spondylolisthesis, one with normal alignment, one with positive sagittal alignment. With increased sagittal alignment, it's reported with poor SRS 22 total score, hence more disability. If the C7 plumb line in front of the hip axis, those associated with disability and more energy expenditure to give themselves upright position, as example for the C7 plumb line. So for those high-grade spondylolisthesis, the spinal deformity study group did divide them to type 4, 5, and 6. Those are for the high-grade spondylolisthesis. So the guideline for management for type 4 is reduction is not required. For type 5, reduction and realignment should be preferably attempted, but type 6, reduction and realignment appear mandatory. So, but what are those types? So if we are talking about the high-grade type 4, is the balanced pelvis group and balanced spine. Type 5 is retroverted pelvis, and which will be with balanced spine, but type 6 with unbalanced spine. This is an example again. This is balanced pelvis, balanced spine, high grade. This is unbalanced pelvis and balanced spine. This is unbalanced pelvis and unbalanced spine. So now we should consider always an issue whenever you want to reduce the patient is the nerve root, which is stretched, and the risk for the nerve roots. So you should keep in mind the root lengthening limit of 2 to 5 centimeters from the position where it is to the position where you are planning to. So you should consider 2 centimeter limit for older than 20, duration over 2 years, if there is high slip angle, preoperative bending, fixed lumbar lordosis, and superior lumbosacral attempted surgery, and radiculopathy. If you need more than 2, then you should consider staged procedure and or shortening, spinal shortening osteotomy, as in proximal dome osteotomy. For the reduction of high grade, you should see if it's dynamic or not, if it's the disc fused or not, as shown in previous talks, reduction on table or not with proper positioning, and again, finally, reduction by instrumentation. General consideration that those patients with high-grade spondylolisthesis, we need to have neuromonitoring on board, decompression with wide, including the foraminal initially, then followed by disc space preparation and distraction by the cage. And finally, by frequent direct visualization of L5 is needed nerve root. Most of the time it's L5S1 for stretching and then reducing by instrumentation. For example, if such a deformity, then you will start after the decompression and preparing the cage, you will put your instrumentation. You will keep those reduction screws. Then you will fix, for sure that the cage is inserted, you will fix this upright, you don't fix it down, and then bilateral simultaneous reduction of those to the spine. For example, you will not gonna fix it this way, otherwise you will not gonna achieve much. So you will put this rod up high, and then you will bring the spine with simultaneous reduction tools to the spine. This is an example for a patient. She has previous surgery with high-grade ischemic spondy, and this is the previous laminectomy which is done, and she has severe pain. We can achieve such a result where there is a cage here, and the rod is fixed in this position, and the spine simultaneously brought by reduction tools back in after inserting the cage. This is another example for bone-on-bone and high-grade or semi-high-grade spondy, but it's bone-on-bone. Some would argue that this, you might not be able to do cage here and from posterior, you need an anterior, especially there is very minimal disc lift in. But looking at that, so this is the cage which is inserted from this to that, and that was T-lift cage. So if again you identify the disc, you will put the osteotome at the disc space after the decompression, then gradual disc space preparation, you will achieve the required reduction and alignment. So classically, if you are talking about those, there is Gaines procedure, which is the excision. It's reported with some patient with permanent disability and permanent drop feet and sexual dysfunction. So that's why it is considered morbid procedure, and that's what mentioned by the previous colleague. So that the Gaines procedure is that you go anterior, you'll see the L5, you remove L5, and then you reduce L4 to the L5. There is some modification of this, that what's presented in the previous talks, that you do kind of decancellation, posterior decancellation, instrumentation for the level above, and then with instrumentation to the pelvis, and you bring the spine back without removing fully the L5 from anterior approach. We know that if you have the patient, which is the balanced group, which is as per deformity study group 5, that you might consider fixing after decompression, then you will need to do good fusion for the patient after decompression, so that the Bowman procedure, which is you need to do a bone graft, which is the classically fibula, through S1 to the L5, and then the studies showed no clinical difference, allograft versus autograft or fibular strout graft. So if you have allograft, you can go with the allograft rather than the autograft. There is the tantalum plug. It's another option that you can use it to do the same result. This is an example for a patient with high-grade spondylolisthesis. He has fairly acceptable sagittal alignment. Now he is in his late 30s. He mentioned that he has his back pain for ages, and we can see the deformity as well as the stenosis. So this is an example of S1 transdiscal screws, and this is the bone graft, this is allograft, and fixation from 3 to S1. You can argue that you might need, this is the screw, transdiscal screws, and this is the fibular allograft. You will use the eccentric ACL guide to be central in the sacrum and center of L5. We can see here the inverted Napoleon hat sign, hence high grade. So putting the transdiscal screws early, initially, help to guide the fibula with the ACL guide to be central. And this is the follow-up. The transdiscal screws, some you can put the transdiscal screw alone, for example. This will give you, again, a better functional and radiographic outcome. And sometimes it's reported in the literature it could be difficult to be placed, but again, studying the image as mentioned by the previous talk and be thorough, you'll be able to do those as well. So this is an example for, again, patient with previous surgery with 2 spondylolisthesis at 2 levels, and it's dynamic, with dynamic instability, with balanced spine. Then at the level, this is above wide facet, hence instability. You could do TLIF or any sort of cage, reducing this with transdiscal screws. You might argue that why there is no screws in the pelvis or pelvic anchorage point. Those are good question. Again, so it could be considered and should be theoretically and practically considered to avoid distal junctional failure. Again, for the high grade, there is a study done that if you are doing only single level without pelvic fixation, it showed that there is high failure rate and subsidence, and the author would suggest going to the pelvis, including the pelvis. So going to the pelvis will help you out to avoid the failure. So this is an example of patient with type 6 deformity with unbalanced pelvis, unbalanced spine. And again, doing the reduction, the sacral dome osteotomy and cage help restoring patient alignment. Type of pelvic fixation, this is now obsolete, this is old. Most of the screws which is used nowadays, iliac screws and the S2 iliac screw, which is the really one of the favorable screw. This is just to show you an example. This is not high grade, it's just a patient with ischemic, bone and bone, and she has severe sacroiliac joint arthritis. But what's the striking here, that the foramina for S2 is really kind of low, really low. So studying the images before will help you out. This is really low lining. If you want to do it as per standard location for S2 iliac screw, this will not be possible and feasible. So you can see it, it's really almost as it's beside the S1 screw to put the S2 iliac screw in proper position, while here it's really will be near hitting the sacral, the sciatic notch, or you will be need to aim upward. So studying the image will help you out significantly to avoid struggling during the procedure. Thank you.